Hello, everybody. It's a real pleasure to have you join me today, and I hope we'll be able to answer many of your questions. So I'm just going to go right in and answer as much as I can afterwards. I do want to start out with a spoiler alert. By the time this talk is over, there'll already be newer data. Just to give you a feel for this, I woke up this morning and I had to read 5 new articles that came out on COVID. So, I'll do the best I can, but we'll see. First, I want to deal with a lot of questions that patients ask me. These are they. I was infected once. Am I now immune? What's the danger if I become pregnant? I've heard about antibody treatment. Is it real? Can I get it if I need it? I hate corticosteroids, and now I'm told they're the best drug for COVID-19. Is there anything to this? I'm taking all these immunosuppressive drugs. Shouldn't I stop them? Remdesivir works, but for who? I've heard that Tocilizumab, that's Actemra, saves lives. Shouldn't everyone have it? Should I get vaccinated? And if so, with which one? And what about telemedicine? So let's take this on. First, a very high altitude look at which tests for SARS-CoV-2 are best. The one that's really very good is the one where they put something up your nose and then take it out and you sneeze and all that stuff. Those tests are really very good. They're very sensitive. They get the whole virus. They're about 90–95% sensitive. They also pick up viral fragments, however, and that's a problem. For example, some of my friends in Italy have remained positive for weeks on end. It's not because they're still sick with the disease, but some viral fragments are still wandering around in their nasal passages, and it's not the total virus, but it's still a positive test. So all of these things have to be put into their context. There are a whole bunch of rapid tests around. Unfortunately, they're about 50% false negative. So that means it may be read negative, but in fact be positive 50% of the time. There are 2 of them that are good. The AbbVie product and the Expert Express product. Those rapid tests are about 90% correct. There have been a lot of questions about the nasal versus the oral swab or the saliva swab. They're both good, and I'm going to show you a little data about that. The saliva tests really may be the up-and-coming thing. Let me show you about that. This is a study that was done, which what they did was they had people spit into a tube, 2 milliliters. It's about, a half a teaspoon. And they were comparing that to the standard test. And what you see here is that the positive predictive value, that means if it's positive, is it correct? The saliva test and the nasal test were the same 97% of the time. And when they were negative, they were both negative 95% of the time. You put it all together, agreement between the salivary test and the nasal test was 99%. Bottom line, when it becomes available, I think the saliva test will do just fine. You know what may happen, and we may be able to get some of them at home. Problem there is it's possible that we don't know about the storage. So you get it at home, you spit in a tube, you send it in. If it takes a couple of days, it may no longer be good. So there's still things to learn. I told you, sometimes I have trouble with this. Here's one of the questions. I was infected. if I was infected and I recovered, am I now immune? And here are the data. This looked at 12,000 UK health workers, and they measured the spike for the virus. That's the best part to measure. And they compared it to 11,000 people who were negative. And what you can see here is over, I think it was 6 months follow-up, 1/4% of the patients got reinfected. And about 1% had a positive culture. But remember what I told you about that. So it looks like once you've been infected, you don't get reinfected for at least 6 months. So there must be some sort of immunity. The problem is when we get to the vaccination, there are a few issues there that we need to talk about. But if you were infected, that is, if you were PCR positive, you probably won't get infected very frequently. What about if I become pregnant? For the males, that's not such a question. However, this looked at a group of patients, 250. Notice this group of patients was a little different than many you often see. Here, Hispanics made up most of the population. And what you see is that in patients who got infected and who were pregnant, 5% of them got severe disease, and 2.4% required hospitalization. So what's the answer to that? If you're pregnant, what's the chance of you getting really sick? Very small. Not none, but certainly not higher than the normal population. Here's another question. I've heard about antibody treatment. Is it real? Can I get it? There is a certain person in the White House who did get it very early. It's a little complicated question here. If you look at the middle here, this gray thing, that represents the spike. And on the spike, there are 4 different places where antibodies can attach. When an antibody attaches to the virus, it kills the virus. So there are 4 classes available. And it's a little tricky, but the bottom line is if you get a class of antibody that is able to attach to more than one site, then it's very unlikely that the virus is going to be able to mutate around it. And so the antibody will be very, very effective. We know viruses mutate. Influenza viruses mutate, you know that. Coronaviruses do too. So the antibodies that we're looking for are the ones that hit more than one of these sites. And this is an examination of one of those. This was a double-blind randomized trial in 41 different centers, and different doses of the antibody were given. And if you look on the left, you can see that the dose of antibody, the higher dose, in fact, eliminated essentially 100% of the viral RNA. So it got rid of the virus. Did it make a difference symptomatically? Well, yes, it did. On this side, you can see, looking at the placebo versus the treated group, and lower means fewer symptoms. And you can see that the patients who were given the antibody not only had fewer viruses, but felt better. So this is a thing that probably will be coming out and will be useful for most of us. One of the problems is, of course, it's going to be very expensive. Another question. I hate corticosteroids, and now I'm told they're the best thing. Is there anything to this? This is actually a somewhat difficult question, but someone looked at this. They looked at all of the literature, and they only found 5 studies. 4 of them were retrospective, looking backwards. 1 was kind of looking forward. 3 of those 5 showed positive result, and 2 did not. but there was one one controlled randomized study, and it was called Recovery. What they did was they gave about 2,000 patients dexamethasone, that's a strong steroid, and they gave 6 milligrams, that's about the equivalent of 30 milligrams of prednisone for 10 days. And they compared them to twice as many people who did not get it. And here are the results. You can see in orange that there were fewer deaths in the patients given the dexamethasone, and there were fewer complicated problems after mechanical ventilation, but it did not seem to make a difference in patients who had mild or moderate disease. So this is the only controlled trial, and it seemed to show that about 30 milligrams of prednisone a day for 10 days made a difference in severe disease. So what happens if you're on a low dose of steroids? You'll see later that those of you on a low dose are at higher risk of getting sicker. But even if you're on a low dose and you're really sick, using high dose dexamethasone or prednisone will be pretty effective. Another question. I'm taking all these immunosuppressive drugs. Should I stop them? Here's a study. It was a study looking backwards, so it isn't quite as good quality. And what they did is they took about 1,700 patients with various connective tissue diseases, not just scleroderma, but lupus, RA, all sorts. And they compared it to 2,600 who did not have connective tissue diseases and were not treated with biologics or targeted synthetic DMARDs. Biologics are the drugs we all know, like Enbrel, Actemra. Targeted synthetics are drugs like Xeljanz. And what you see on the right is that the mortality between those who were on those drugs and those who were not on those drugs was the same, i.e., using the immunosuppressives did not result in increased deaths. Okay? So these are the data, and this just came out very recently, of course, in the meetings. But sorry, guys, there you go. The ACR put out some recommendations, and they aren't quite as clear or clean. Here's what they said. If you were normal, you weren't having any troubles at all, then the top portion, you continue all your drugs. If you had exposure to the coronavirus, but no symptoms and no signs that you were positive, they suggested that you continue your regular drugs, but stop the immunosuppressives. Now, that does not square very well with most people's experience, and certainly doesn't square with the study you just saw. Most people who had family members with exposure who weren't positive and who weren't asymptomatic, I don't believe you have to stop this. I think these guidelines, while very nice, are a little outdated. Things move too fast. What about those who actually had COVID or were positive? The suggestion is to stop most of the stronger drugs. Hydroxychloroquine may be continued because it doesn't do much harm, doesn't do much good, but doesn't do much harm. And NSAIDs, they said, should be stopped, but the more recent data says NSAIDs do not need to be stopped. So let's say you do stop. When do you restart? You restart 17 days after the symptoms resolve. So if you put everything together, in my mind, if you have COVID, stop your stronger drugs. Restart about a week or two after all your symptoms have resolved, and that may take some time. What's the danger? Well, your disease may flare. But I think you and your doctor have to get together to make decisions in the situation where you've recovered, you're not feeling completely normal yet, but your disease is flaring. You'll have to work that out with them. Now, there are drugs that work. Remdesivir works, but for whom? Here's a look at this. Remdesivir is given intravenously, and you give it on day 1, and then you give a different dose out to day 10. And this looked at people who were very severely sick. And they looked at a measure that tells about symptoms, etc. And you can see there was a mix of different ethnicities. And most of these patients were quite severe. And what you can see here in blue is that the time to recover on remdesivir was less, there was less severe disease, and there were fewer deaths. So in severe COVID-19, those people who are on a ventilator, require oxygen, their oxygen is low, remdesivir does work. Of course, you never get something for nothing. So what about side effects? Here, you can see the side effect profile, and SAE stands for serious adverse event. And there weren't an increase in side effects for this group of patients. There weren't an increase in the more severe ones, and multiple other things were looked at in the laboratory, et cetera, and they did not seem to make a problem. So for remdesivir, works in severe disease without an increased incidence of significant side effects. What about Actemra? If Actemra works, why shouldn't everyone be on it? Sometimes I can't get this machine to work. There you go. The biggest problem has to do with what Actemra actually works for. This looks at cytokine storm. That's what it's called. There are various names for it. Bottom line is that the various kinds of immune cells, NK cells, B cells, T cells, all work one against the other. They lose their energy, but in doing so, they release a huge number of proteins in the blood. You can see them there down the bottom in the middle, one of which is IL-6 or IL-1 or IL-10, and Actemra affects these. So in severe disease, there's reasonable, not perfect, but reasonable data that it works. What about more moderate disease? So this looked at about 240 patients. The numbers don't add up there. There's a number missing. It should have been 116 on tocilizumab. It doesn't matter. Various ethnicities. And what was done here is they looked at patients who had moderate disease. They had some x-rays that were positive. They may have required some oxygen. They had some fevers. And what you see here is that the odds, the hazard ratio, the odds compared to placebo of getting tocilizumab versus placebo, the odds were not different if you got the tocilizumab versus you got the placebo in terms of requiring ventilation, death, or worsening of the disease. You see here the bottom line, the p-value, it has to be less than 0.05 to be real. So for moderate disease, it does not, like tocilizumab, Actemra, is actually useful. Well, let's go on to vaccinations. One of the big questions I'm asked all the time by my patients is, should I get vaccinated? And then, if so, with which one? Got to give you a little background here. First of all, can the vaccine cause my disease to flare? Now, this is a study which isn't in COVID, but it's in shingles, because we don't have the data in COVID yet. but it's similar. It's about 600 patients, and they were given the vaccine. And then it was looked at whether the vaccine caused the disease to flare in people who are on various background medications. And what you see here is that if you look at Xeljanz or hydroxychloroquine, methotrexate, etanercept, Actemra, any of these drugs, there was not an increased incidence of flare, except for steroids. If patients use steroids, they did have an increased incidence of flare. So how much steroid is the too much steroids? In principle, of course, any steroids. But the fact is that we don't have actual data on this. I think what I would suggest is that if you're on less than 10 milligrams of prednisone a day or equivalent, you probably would be okay. We don't have actual data for that, but in other circumstances, that kind of low dose seems to be reasonably safe. What you see here is that if prednisone was greater than 10 milligrams a day, the chances of you getting severe COVID was about 100% higher, double, than if it was less than 10 milligrams of prednisone a day. Okay? So it repeats the same thing. Most drugs do not result in flare or increased severity except for corticosteroids. Next slide. So this asks the question a different way. Will it work if my immune system is suppressed by medications? Next slide. Again, we don't have the answer in COVID yet because we just don't have as much data. But this looks at pneumococcal vaccination. And what you see here, this drug is one of the drugs like Xeljanz. It's called Rimvoq. And the response to pneumococcal vaccine was about 68%. If you weren't on these drugs, the response was about 80%. So it looks like there's about a 10% decrease in good response on an immunosuppressive drug like this one. I think we don't have the data yet, but I'm guesstimating that that's what to expect. In COVID, the responses are usually 90 to 95% satisfactory response. So you can expect, if you're on some of these drugs, an 80 to 85% good response. Next slide, please. So let's look at these vaccines. Next slide. If the vaccine is given into the nose, as you see in C, it immunizes the mucosa of the nose and the lungs, just like in nature, so to speak. If it's injected, the immunization is only in the lungs, so it's not quite as good. It's another reason that the intranasal vaccination might be good in the future. Next slide. Now, there are many different ways of developing these vaccines, and I'm going to go over some of them. I don't want you to go crazy with this, but if you start with an inactivated vaccine, like this one here, C, what you do is you get the whole viron, the whole bug. And so you get a good and very complete response. Unfortunately, if any living vaccine happens to make it through, there's a higher chance of side effects. And there are different proteins too. If you use a live attenuated vaccine, like you see here, okay, this one is the kind you can get from the intranasal route, and it's going to be very good. but it is live attenuated, and I would recommend not using anything that says live in it. Reason for that is that before immunity is developed, if there's a live vaccine, it can take off inside you. So you don't want to use a live vaccine, even though it's supposed to be safe. There are other ways that we can do. What about various proteins like E, F, and G? Those are bits and pieces. They are very likely to be very good, but because they're not the whole virus, you don't get quite as good an immune response. On the other hand, these are the ones that are the way that influenza vaccines are made. So the methodology is really well worked out. So recombinant proteins are not ideal, but they're really pretty good. How about replicating incompetent vectors, H? Well, there you're going to see a little of E, F, and G and a little bit of D. So you're going to get a reasonably good response, but it's live attenuated. So be careful. DNA vaccines, like the ones in L or K, this one here, results in a bit of the DNA put into the mechanism of the cells, and then the cells in your body produce the vaccine. It's really pretty good, but it doesn't result in the kind of large immune response that you'd like. Remember, we talked about the different antibodies? It's more directed, so it might not give as good a immune response. The mRNA vaccines, that's the ones that are out there now, they do a pretty good job, but you got to be careful because you got to keep it very well frozen, minus 80 or minus 90 degrees. The other one is developed in animals. We're not going to see much of it. So when you look at this, you see how complex all these vaccinations can be. I think sort of the bottom line is no live vaccines. That I would not do. DNA vaccines may be somewhat limited. The RNA vaccines, the recombinant proteins are very likely to be quite useful. You can think of it that way. Next slide. So one of the things people worry about is how come it got done so quickly? If you look at the traditional way of things being done, the first phase takes a year or two. The second phase takes a couple of years. The third phase takes a couple of years. Then it goes to the FDA, and then the production of it takes another year or so. What was done in this case is in the bottom. The phases were overlapped, and most importantly, the companies took a chance with some help from government funding and started developing the vaccine even before all the data were in. And by doing that, it didn't decrease the care with which these things are developed. It just sped it up a lot. And that's why instead of taking 10 years, it might take a year and a half. Next slide. So how many of them are there? Well, this shows you that. You can see the different colors represent the different ways I told you about making the vaccines. The light blue are the RNA vaccines. The greens are the ones that are the usual ones with like AstraZeneca is made, and it's very well done. And it's not a live vaccine. And what you can see is there are 120 in the preclinical phase. That's before being put in humans. There are about 23 in phase 1, which is early human use. There are about 14 in phase 1, 2. That's later use and trying to find the right dose. There are 9 or 10 in phase 3, and we're already knowing that several of them have been licensed. So you can see there are a huge number of these coming down the pike. Next slide. So what about these? The AstraZeneca one, if you take 2 doses, gets good seroconversion. You don't necessarily get a huge response, but you get sufficient seroconversion in about 90%. The Gamaleya I know very little about. We were told they'd get good conversion, but we have no data, so I'd wait on that one. The Moderna one is really developed very nicely. And what you can see here in a larger study that about 0.1% of the patients got sick despite this, and that only, I'm sorry, let's make this clear. 0.1% of the patients who were given the placebo died, but 0.005% given the vaccine died. In other words, very effective. We'll talk about side effects in a minute. The Pfizer vaccine seemed to work just about as well as the Moderna one, but we don't have the same kind of data. Now, what about side effects? Well, side effects are kind of funny. If you think about what is being done, a foreign protein is being injected into the body, and the body's responding to that in a protective way. And when it's responding, one of the normal things you get responding to a foreign protein are things like chills and aching and fevers, and you may feel sick for a couple of days. You might call those adverse events, or you might say, you know what? It says that it's doing what it's supposed to do. Well, those responses occur in 70 or even more percent of patients. They usually last 2 to 3 days. They require Tylenol. They clear up. And so I'm not sure that side effects are more than a sign that the drug is doing what it's supposed to be doing. Next slide. What about these side effects? Next slide. One of the things you have to think about is what happens when you give 2 shots, because most of the time you have to give 2 shots here. And you can see on the left, aches and pains, tiredness, fever, chills, headaches, the things you expect. And what this slide shows is in the second shot, those side effects increase. And they increase significantly. But again, that's because the body's doing what it's supposed to do. Next slide. One of the issues is once you've manufactured it, getting it to the places where it's going to be given out. And with the mRNA ones, you have to be very careful, as I told you. You have to transport these things at -90 or at least minus 20 degrees. And you have to be very careful about when you give it out because you have to know what's going on. You have to be able to follow the patients further on out so we can find out about unusual side effects. Most of these studies really go out for about 2 months. But now that they're being given to patients, if they're being followed accurately, they're going to be given to millions of patients. And even the rarest of side effects are going to come out. Will there be severe side effects? Of course there'll be severe side effects. You never get something for nothing, but it's going to be very rare. And if you think about it in terms of, would you rather get severe COVID, or would you rather be protected? Would you rather have a 9% chance of dying from COVID? That's the number. Or would you want to live with potential side effects? I would go with getting the shots. Next slide. The NIH and CDC have come out with who's going to get the shots when. And what you see here in phase 1A, those are the high-risk health workers, the ones in the ERs and things of that sort, the ones who see patients. Also, the ones in nursing homes. Phase 1B is the patients who have underlying conditions or are taking medicines which put them at greater risk. So I believe that all the scleroderma patients are 1B. And then there are later people later on. How fast will it come out? Well, there are about 20 million people in the 1A phase. So that's going to take a month or so. And then probably in February or March, the 1B people will start getting the medication. So that's what I would look for. Next slide. I want to finish up talking a little bit about telemedicine. Next slide. This was an interesting study that was done. They looked at 1,500 patients who had various of the connective tissue diseases, and about 15% of the patients stopped their medication, their disease-modifying drug. 79% of them did so without consulting their physician. They just stopped it. And so it's pretty clear that there has to be some better communication between the patient and their doctor to make sure that everybody's on the same page. Because remember, the drug can result in flare of disease, can make people extremely sick, and not all the time will be able to recapture the patient's disease. Next slide. This looked at a large number of studies. They looked at 53 studies, and these were reviews of other studies. So 53 reviews looking at how effective it was, 16 looking at cost effectiveness, and 15 looking at patient experience. And I just highlighted the two that I wanted to look at. One, it asked the question, which was better to do? Go in person or go by telemedicine? And in 80% of the cases, the two were equivalent. All of the patients accepted the telemedicine appointments very well. Now, there were problems. You can see that on the right, particularly technical problems with feedback, pixelation, poor interfaces. Sometimes the patient just didn't want to do it. And some were just not up to the technical issues. And some of my patients really are that way, and we just use a telephone. Next slide. This looked at some rheumatology patients, and it was a very small study. You see that, 38 patients. And they broke the patients up into those with inflammatory conditions like scleroderma, rheumatoid arthritis, lupus, versus non-inflammatory conditions such as fibromyalgia, osteoarthritis, osteoporosis. And it turned out that more of the patients with inflammatory conditions wanted to do person-to-person visits. 66 in the inflammatory group versus 41% in the non-inflammatory group. But overall, the telemedicine was satisfying to all the people who did it, about 80%. Next slide. We looked at a small group of patients. We looked at 28 scleroderma patients, 22 RA patients with 2 rheumatologists. We did a standardized kind of questionnaire. Half of the questions were, how bad was your pain? And half of them were, how were you feeling? And here's what you see. The concerns by the scleroderma patients about no physical exam was much more frequent than the RA patients. But about 50% of the patients were concerned that there were no physical exams during the telemedicine visits. On the other hand, more of the scleroderma patients liked the safety and the convenience of it than the RA patients. Again, about 2/3 felt good about the telemedicine for that reason. If you looked at which patients felt the drug, the telemedicine was doing well, it was percent of the patients with scleroderma than the RA. But overall, most of the patients felt that the telemedicine visit was very good, and most of them were very satisfied. Next slide. From the physician's perspective, is a little different. More of the doctors taking care of scleroderma patients really felt that it was a problem that they couldn't examine them, more so than the RA patients. On the other hand, the doctors taking care of the RA patients felt it was safer for the RA patients, a small percentage overall. The physicians felt that about 80% of the physicians taking care of scleroderma patients felt that telemedicine was good, compared to a much smaller percentage who felt taking care of RA patients who felt it was good. Satisfaction, a little lower than in other studies. So there may be differences in patients in terms of telemedicine, or in terms of how the doctors viewed what was going on. Next slide. Next slide. So what we've done is we've reviewed questions frequently asked by patients. We looked at vaccinations in North America, the good, the bad, and the ugly. And we discussed some aspects of telemedicine. I hope I've been able to answer some of your questions, but I'm sure there are more, so let's go through some of those.
Emmanuel, can you stop sharing the screen, please? Thank you very much, Dr. Furst. A very informative talk. I really appreciate it. And one thing I forgot to do was talk about our disclaimer and just remind everybody that today's talk is purely educational, and that the Scleroderma Foundation does not endorse any specific treatments, drugs, or research trials. Because scleroderma affects all patients differently, treatment approaches that may be appropriate for some patients may be less suitable for other patients, and any treatment decision should be based on knowledgeable discussions between patients and their clinicians, such as Dr. Furst. Thank you.
And let me point out that I am not paid by any of these companies, and I don't endorse any of them. This is straight out the data.
Thank you, Dr. Furst. And while I believe that you did really capture a lot of these questions, I kind of think it would be great to look at this as a recap. And this way, as I ask a specific question, they're focusing on your answer, specifically where it was a little more broader as we were going through the slides. So the first one is, why are scleroderma patients discouraged from taking any live vaccines, i.e. flu shots, and now the COVID vaccine? And have there been studies done on these findings?
The reason we worry about live vaccines is the body has not yet developed a response to those influenza or the coronavirus. So the virus, if it's alive, can just take off in the body instead of doing what it's supposed to. A vaccine producing a protein which inhibits the virus. Those live vaccine could make people very, very sick.
Thank you. Should scleroderma patients reduce their dose of CellSup with the COVID-19 pandemic?
Well, one of the things we think we're seeing is that using the immunosuppressives, including CellSup, does not result in more admissions or more severe disease. So the answer is no.
Thank you. Can you address taking the vaccine with active scleroderma, and while on an immunosuppressant, do we stop the meds? If so, for how long, and when do you stop them and restart? I remember at his last presentation, he mentioned taking it, and of course I will consult my doctor. I just want to hear his thoughts as a renowned specialist and researcher.
So we went over that a little bit. It's not a black and white issue, but generally speaking, if a patient, the data overall, in my mind, seems to say that using the immunosuppressives does not result in a flare. Using the immunosuppressives, if someone isn't very sick, does not result in decreased body's ability to fight the coronavirus. So in general, you probably don't have to stop your medication. However, if you've got other things going on, for example, if you're overweight, you've got hypertension, you've got diabetes, and you're feeling lousy from the coronavirus, then you probably would stop the medicine. What's the issue here? Well, look, the virus takes about what, 2 weeks? If you stopped your medication the day you started feeling sick, most of it would not be out of your body before you're ready to get better. So it really becomes a somewhat tricky thing. I believe that if you have a lot of comorbidities and you're feeling particularly bad, you should stop the medication.
Thank
Oh,
you.
the second part was, when do you restart? I
Yes.
think most people kind of agree that about 1 to 2 weeks after your symptoms have resolved, it'll be safe to restart.
Thank you. If also have severe allergies and pre-dose with prednisone, Benadryl, Zyrtec, will the pre-dose diminish vaccine effectiveness?
Very good question. I think if you're using higher dose of prednisone, the answer is yes and yes. That is, it may decrease the body's response, and it may result in more severe disease if you get it. So I think you got to be pretty careful with prednisone. The other medications you can use.
Good. Thank you. Is it true either immunocompromised or immunosuppressed people are not allowed the vaccine during its quote unquote emergency use authorization period or until more data is compiled on these subgroups?
Well, you always want more data. I'd love to have everything perfect, but we're not going to. I think that patients on immunosuppressives, because they could get sicker if they get sick, should be vaccinated. I believe that scleroderma patients on immunosuppressives belong in 1B, as I spoke.
Yes. Thank you. If someone in your family has had the virus, but is both past the isolation period before the 90 days immunity has expired, are they able to breathe in virus particles and still transmit to you?
God, what a good question. First of all, um, we don't know how long the immunity lasts. So far, we know it lasts for 90 to 119 days, apparently. But for some people, it may be a year. In fact, we're anticipating in the long run that these injections will be yearly and that the immunity lasts a year. So now we'll take a patient who got over her disease. She is now immune. If she takes in any of the virus and it's in her for any period of time, the virus will be killed. And consequently, it should not cause a problem. Having said that, I think it really does make sense to try and keep away from people who have active COVID. So if you're going to inhale the bug, you probably won't do as much harm. But the trick is not to inhale the bug in the first place. Masks and the usual stuff.
Thank you. I'm noticing some of the questions coming up, but as I mentioned, please wait until we're done with these questions so I don't try to read through some that we've already answered. It would be a lot more helpful that way. Next question. Should someone who has had the virus still get immunized?
Remember what we said. Only 1/4% of patients who were infected get reinfected. So theoretically, they should be immune. And for everything in the world, they should be immune.
Thank you.
It may even be possible that if you get vaccinated, you'll have a higher chance of a side effect. But we don't actually have any very good data. I think that if you don't have a lot of comorbidities, and if you've had the disease, And if you've recovered from the disease, you probably don't need vaccination right away. Might you need it 4 months from now? Yes, but by then we'll have more data and be able to give you better answers.
Thank you. I'm a kidney transplant recipient. My question is whether or not it is safe for me to get the vaccine while having an autoimmune disease and taking immunosuppressant drugs for my transplant. I have heard conflicting recommendations.
Well, it's the same answer as before.
Yes. Okay. Okay, next question. With the mutation currently seen in the UK, what's the expectation for the current vaccine efficacy for that mutation?
So remember what we talked about in antibodies. If the vaccine results in a broad range of antibodies being produced, there is not going to be any problem. Are we guaranteed that the next mutation will be taken care of? No, we cannot. If you think about influenza, every year we have to make up a different mutation, a response to a different mutation. I don't think that's going to be different for coronavirus.
Thank you. You kind of went over this, but I guess it's more of just you reiterating it. I've had scleroderma for 12 years now, and I'm a registered nurse, and she's actively working in the hospital inpatient ward and says, my hospital is giving out the Pfizer COVID-19 vaccinations. Should I receive it? I read that this vaccine affects the immune system. Isn't that harmful for autoimmune diseased patients?
On balance, I think she should get it without any question.
Thank you. Let's see. I'm sure everyone will want to know where scleroderma patients stand in taking the vaccine. I saw this question on ABC's website. It lists high priority. You did pretty much go over this, but just confirm it. Medical conditions such as obesity, COPD, diabetes, heart disease, and chronic kidney disease. No mention of autoimmune diseases. Where does scleroderma fit in?
There'll be 1B in my mind. And I think that if my patients, if the vaccinators need documentation, you can ask your doctor to send a little note saying, I have an autoimmune disease and I will be at higher risk and therefore need the vaccination.
Thank you. And you kind of answered this too, but there is a little difference to the question. So let me know if you feel that you can elaborate a little bit more. Scleroderma patients generally fall into two categories, those taking immunosuppressant drugs and those that are not. These are my general concerns, that a vaccine might unsafely activate the immune system, and the other is that immunosuppressant medications might interfere with the vaccine's effectiveness.
So the answer is no and no.
Thank you. Let's see, main questions I have. Since the trials for the new vaccines, Pfizer and Moderna, did not include those with immunocompromised patients, do you feel that they are safe? Well, you pretty much did say this already. For us to take, go ahead.
No, you're right.
Do the benefits of the vaccine outweigh the risk? I think you have, but elaborate.
Yeah, no, in fact, remember I said I have a spoiler alert? Well, this morning, there was an article that came out looking at a small number of older individuals. That's not the same as autoimmune patients, but older individuals, remember, they're the ones at higher risk. And it turns out that they responded just as well as younger individuals to the vaccines. So I'm anticipating we're going to get pretty good response when the autoimmune community gets involved. Not proven, but every reason to expect it.
Thank you. I'm interested in learning his thoughts on high temperature spikes in the RNA developed vaccines reported up to 104 degrees and how this affects decisions to take the Pfizer and or Moderna vaccine.
Okay. The answer is, as I said, it probably is a sign that your body is responding to the foreign protein and developing the antibodies. Certainly, it feels very uncomfortable, and certainly you ought to be using the Tylenol, and don't be afraid of it, up to 3 grams a day. But I think The fever per se is not dangerous in adults. It's the disease that's dangerous.
Okay. Any updates on the cause of the anaphylactic reaction, since the Pfizer vaccine does not have the preservatives and culture base normally associated with earlier vaccines?
Yeah, I think that's a good question. The fact is that what causes anaphylaxis? It's going to be some amount of foreign protein, and whether it comes from how the thing was um, purified, or whether there might have been a slight amount of contaminant in very small amounts, or whether the individual had already had an allergic response to a similar protein. Those are the things that might have resulted in anaphylaxis. And the result has been that people who have had severe anaphylaxis and are those allergic people who, are allergic to perfumes and everything under the sun might be at higher risk. We don't know that. But we do know that a very small percentage of patients are going to have severe side effects. And on balance, you try not to be those people, that's for sure. But on balance, it really is important to get vaccinated.
Thank you. I am allergic to penicillin and shellfish. Is the vaccine safe for me?
If you're allergic in terms of a rash, we would not expect much. If you have had documented, not that your mother said that you were allergic, but documented anaphylaxis, you might be a little bit more careful, and you might wait till the intranasal one comes out.
Thank you. So since I just want to reiterate then, because one of the questions did go back to what you said about needing a doctor's note. So it's up to our members to go to their doctor and say that I am considered in this category, the 1B category, and ask for the letter as a priority for the for that group to get the vaccine, correct?
Yes. What I would recommend is you call up wherever you're going to go, whether it's Cedars or Hoag or one of the hospitals, and ask them whether they will need documentation. And if they need documentation, then you get it from the doctor. If they don't need documentation, they just take your word. It'll make life a lot easier for everyone.
Thank you. So we have somebody that's saying, I'm not on an immunosuppressant yet. Should I take the vaccine first when it's available and then start the immunosuppressant after?
If your disease activity allows you to wait, I would do so.
Okay. Let's see. I have to take my second shingles vaccine. How long do I have to wait to take the COVID vaccine?
Good question. Turns out that the shingles vaccine, the first shot, gives you 90% immunity, and the second shot only raises it to 95%.
Wow.
So you really don't need that second shot very much. And if you have had at least a month, preferably 2 months, since then, you can go ahead with your vaccine.
Thank you. Do any of the vaccines that you discussed today, are any of them live?
No.
Considered live? No. Thank you. Okay. By the time our group will get a vaccine, there will be both the mRNA vaccine, Pfizer and Moderna, and a DNA vaccine, Oxford, approved for EUA and FDA. Which would be better for me as a scleroderma patient?
Okay, so the Oxford one is, I believe, the combination, and I could be wrong, with AbbVie and Oxford working together. That's actually an adenoviral vaccine. So what happens is a bit of the coronavirus protein is attached to an adenovirus. The adenovirus is injected. The adenovirus goes to the cells in the humans. The adenovirus then dies. That's been well documented, leaving the protein in the cell for the body to respond to. So it's got a much longer record than does the Moderna and the Pfizer, because it's been done for influenza for years. But it also looks like it's not quite as effective as the Moderna and Pfizer ones. If I were in your shoes, I'd probably use the Moderna one. Why? Because the Pfizer has to be transported at -80 to -90 and is likely not to be quite as stable. They say that it's stable at -20 for several days, and even at normal refrigerator temperature, which is 20 degrees, for several days as well. But there might be a small chance that some of it might be inactivated. For the Moderna, that's not going to be as big a problem.
Okay. Let's see. Next question. Are you learning anything specific to scleroderma patients who survived COVID-19 as far as treatments and virus course?
Good question. Yes, we are. Have we learned it? No, we haven't. What we have is a worldwide registry. There are two of them, one from Europe and one from the US, where all COVID-19 patients are hopefully going to be registered and followed. So we will learn that. We don't know it yet.
Thank you. Let's see. If severe allergic person, best to take in allergist office then?
Yes, not necessarily an allergist's office, but someone who can respond rapidly to an allergic response. Most internist office family practitioners, they're supposed to have the epinephrine and the training for a severe response. I really don't think allergists per se any more so than any other good doctor. If you feel scared, do it in a hospital.
So I think this is sort of the same. Tell me if it's not. I did have documented anaphylactic shock from penicillin. What group would I be in?
The group where you have to be very careful when you get the drug. You still would be in group 1B, but you might want to go in to a clinic in a hospital, let them know this is the issue, and please have yourself being on direct observation for a couple of hours after the dose.
Thank you. I think you've already answered this in part. I am on 15 milligrams prednisone daily. Should I get the vaccine? If so, specific vaccine strains should I get?
You are likely at a higher risk to have a severe COVID, and you probably, if you could, should work very hard at getting yourself down to 10. You're not going to be getting the vaccine for another 2 months anyway. You do have a chance to move it down and try and use other medications to handle your disease than the prednisone.
Thank you. Most health facilities will not disclose which vaccine they have. How do we find out where I think they meant Moderna vaccine is?
So I think that's a very good question. I don't have an answer for that. I think that if you are assertive enough, it'll take you longer. You're going to be on the phone for a while before, but get to the administration and say, we have every right to know, and which one are you using? I don't have a good answer. Best I can think of.
Thank you. Next question. Opinion on using ivermectin, I hope I'm saying that right, for prophylactic or therapy for COVID-19?
Could you spell that?
I, V as in Victor, E, R, M as in Mary, E, C as in cat, T as in Tom, I, N as in Nancy.
Don't know. If they can tell me what it actually is, then I can give you a much better answer. But
thank you. Leslie, if you can give me that information while we're asking questions, I'll share it with him. Next question. Do these vaccines affect fertility in men or women or their offspring?
Other vaccines do not. It hasn't been looked at. I told you the data that is known on pregnancy. I would assume that this vaccine, depending on the platform that's used, is no different than any other vaccine. Data not there, but I would really be surprised if this affected fertility in any way.
Thank you. Is there a timeline for the nasal vaccine?
Good question. Answer, probably won't be out till summer or fall.
Okay. I think you've answered a bit of this, and the other part, not sure if they'll be able to get their way on this. Which vaccine is better option in your opinion, Pfizer versus Moderna? And are we able to request which vaccine we want when it comes time to get vaccinated?
As I mentioned, the two drugs in terms of efficacy look quite equivalent. The data for Moderna is more clinical and consequently a little bit more reassuring. The data on transportation is a little bit more difficult for the Pfizer. So in all things being equal, I think the Moderna would be the one to try and take. It's not clear how any hospital will do this. Are they going to do day A with Pfizer and day B with Moderna, or are they going to just mix and match during the day? I think if you had the freedom, I'd go with the Moderna. If you can't get a good answer, I think the fact is that both are going to work. I think there may be differences around the edges, but if I were told, look, I can't tell you which one it is, do you want it or don't you? I'd say take it.
If you get the Pfizer vaccine for the first shot, do you have to get the same vaccine for the second shot, or can they be mixed?
No, do not mix. They're slightly different. That's one of the reasons you saw that slide I put on, that people have to be at centers where the patients are very carefully followed, because they're going to be giving out millions of these things, and someone has to keep track of who's doing what to whom. So it really is important that you get the same company, or sorry, the same vaccine being given to you both times.
Thank you. Any risk for nursing mothers?
Data unknown. I can tell you data from other vaccines, and the data are that you really, the vaccine does not get across the milk, and that which does is broken down in the stomach of the infant, assuming the infant is more than 60 days old. The antibodies will probably get across, but they will do no harm and they may help.
If you think you're exposed, is zinc, vitamin C, and D, it's not really written the way I'm trying to say it. If think exposed, is zinc, vitamin C, and D needed to be started right away? I think that's what they're trying to say. If so, what strength of each?
So the question is, are there data that say that vitamin C and zinc, what was the third one?
Vitamin C and D and
Oh,
zinc.
okay. There are some data in general viral illnesses that vitamin C in kids actually decreases the severity and duration of their viral illnesses. On that basis, it's been being given to many, many, many people. Vitamin C at a gram a day, at worst, is going to be excreted in the urine. So it's very unlikely to do any harm. It is an acid, so it could upset the stomach. Zinc has been shown in the test tube to be very good at helping the body develop immunity using what are called T-reg cells. Once more, if you use zinc in the usual dose, not 3 or 4 tablets every day, the usual dose that's in the multivitamins, or separately as 2 or 3 times the minimal daily requirement, is going to be safe to use, might help, not proven, but except in the test tube, and will be gotten rid of by your body if it isn't needed. So vitamin C and zinc, quite okay. Vitamin D, different question. The concentration in the blood should be within the normal range and not high, not higher than normal. And under those circumstances, as it does for any immune response, helps regulate the immune response, not specific for COVID.
Okay. She also asks, besides vitamins, what other things would be helpful? Also mention sleeping on stomach or anything else.
No, sleeping on stomach relates to people who are super, super ill, not the normal kind of person who might have a cold. So I don't think that's an issue at all. We have no data on any other foods or diets that make any difference. I am a believer in the placebo response. I think if you can harness the power of your mind by using your belief in some approach or other that's safe, that will get you a response. There are multiple studies that say the placebo response is about 20 to 30%. That doesn't mean you just feel better. It means that your immune response has changed. Your sedimentation rate has changed. So if you can harness the power of your mind, do so.
Thank you. And I don't know if you'll be able to, if you have this data, but the question is, I had a very severe rash after taking penicillin. What kind of response to the vaccine might I expect?
So from what you told me just now, obviously I haven't seen it,
Right.
it does not look like an anaphylactic response. It might be useful to have some around. It might be useful to have someone around who can respond in case you have a problem. But I think you're very reasonably, more than reasonably safe. You're quite safe to use the vaccine.
Thank you. I like this one. Does the color of the cover of the vaccine vial identify the manufacturer?
Great question. And I have no idea. It would be wonderful if we could figure that out and pass that around on the internet. I don't know.
Thank you. If I have allergic response to the first dose, okay to skip second dose? And if so, how much immunity will you get? If I have COVID, can you walk alone outside with mask on, or will you expose others?
That's a good 20-minute question.
I know.
I think, first of all, the response to the first dose without the second dose is going to be both lower by a factor of 5 or 10 and much shorter. We don't know that it will last very long at all. I don't know what an allergic response means. If you have anaphylaxis, that's one thing. If you have aches and you have a small rash, that's another. If you have some achiness and a little fever and your joints ache and it goes away in 2 days after the first dose, you should take the second dose. If you can in any way control the symptoms of response, remember what I said, it's response rather than adverse effect. With a little Tylenol or some simple medicines, I would definitely recommend the second dose. Didn't understand the last part about walking around. Could you read that again?
Sounds like this person saying, if I have COVID, can I walk outside with a mask on, or will I expose others?
You will expose others. No and ifs or buts. Even if you use the N95.
Wow. I'm glad you made that clear. Do you believe that the RNA vaccines will have any effect on current and or future gene therapies?
So I think the question is, does a vaccination on whatever basis affect the DNA of the individual who gets the vaccine so that their gene therapy, should they need it, will be affected? And the mRNA certainly will not do that. The DNA, as far as I know, also will not do that. So I think they don't need to worry about future gene therapy. I must tell you, this is not an area that I'm an expert in. All I'm doing is extending my knowledge of immunology to this area.
Thank you. Personal one. Are you giving the vaccine out at your office?
No, I'd love to, but there's a problem. And the problem has to do not with being able to store it, because we have a -80 and all that sort of thing. The problem I have is I don't trust our computer systems enough to be able to follow our patients well out long enough to be safe and to teach others what is being learned. And consequently, I don't think that doctors' offices like myself, just in my practice, should be doing that. But I do believe that at our division or in the hospital where they have the right computer systems for this, for example, well, I was going to say, are they going to use Epic? I think they're going to need to use different EMRs to do this. So it's got to be a larger system with a very good IT department on a day-to-day basis. Doctors' offices, that's going to come in phase 2, not in phase 1.
Thank you. Going back to the person that's on the 15 milligrams of prednisone, they are adrenal insufficient. And if they get down to 10 milligrams, will the vaccine cause additional adrenal problems?
Different question.
Sorry?
I'm listening. I'm thinking this through. It's a
Okay.
somewhat different question.
Yeah.
Most of the time, under non-stress conditions, 10 milligrams of prednisone a day cover adrenal insufficiency. If this individual has been proven to require 15 to prevent Addison's disease or adrenal insufficiency issues, then she cannot go down. I think this is one where her specific issues and the degree to which her body requires, not likes, but requires prednisone will determine how far down they should go. She is in a slightly different position than you or I. Our adrenals put out 5 to 10 milligrams a day of prednisone equivalent on their own. So in a way, she's at the baseline level that you and I are, so that she may not be at the risk that a person who's got normal adrenals and then has this pushed on top of it over the short term is going to get in trouble. So I think she is one of those individual patients requiring very careful discussion with their doctor before making a decision.
Thank you very much. I think we've kind of addressed this. Are we automatically put on a list for getting the vaccine, or is it up to us to be put on the list, and who do we contact? And am I correct in saying that everybody should take it upon themselves to speak to their primary and or rheumatologist and let them know, and then have them be the ones to write the note for the vaccine, confirming that they're in this 1B group?
Yes, the patients need to take the responsibility to get on the vaccination list. They need to discuss the need for requiring documentation, and then they should talk to their individual physicians to get the documentation if it's needed.
Thank you. Let's see. It maybe might be the same as the penicillin, but any different action needs to be taken if I'm allergic to sulfa?
Depends on the allergies. So the answer is the same, yes.
I'm not sure how impressed, I don't know what you mean by this, on college age students who had COVID and returns home for holidays and wants to see friends and family not wearing masks, that they still need to wear masks.
There's absolutely no question that for them, but more for others, despite having had the disease before, that she should be maintaining distances, washing, etc. The fact is, she may be alert, she may be immune, um, um, and she should be not infective. But we just don't know enough. And I really think being a little extra careful, being a model instead of an anti-model of what to do right will be the best for everyone concerned.
Okay, thank you. That was my last question. Does anybody else have any further questions? Let's see. If I live in a house with someone who just tested positive, how do I keep from getting it?
Isolate.
Yeah, that's tough.
Yes,
Really
it's very
tough.
difficult. And a person working for me had the same issue. Basically, luckily, they had a house, a little sort of cottage in the backyard, and the person who had the disease was in the backyard. Food was delivered outside the door. The plates were paper. The clothes were delivered outside the door by the person and were washed. It's a major, major issue when that happens.
Okay. Can a healthy caregiver of a scleroderma patient get in line for the vaccine? If so, what group?
No, they will not get it. I'd love it for them. It'd be the best thing for the patient, but it's not going to happen. That's my.
Okay. I think that this person sent something too quick. For a COPD, if you have COPD and you're using inhalers which contain a steroid, is the vaccine safe for us?
Yes, but they have an additional comorbidity, making them moving them sort of up on the list of people who need the vaccine. I just want to clarify, the more comorbidities you have, by which I mean diabetes, hypertension, obesity, COPD, heart disease, the more of those you have, the higher on the list you become to get the vaccine. And the more important it is for you to get the vaccine.
Well said. Okay, any other questions, anybody? Okay. I have candid esophagitis and on fluconazole. Can I take the vaccine now, or should I wait until the symptoms are over?
If you have Candida esophagitis, you probably ought to be treating yourself on a more ongoing basis because it comes back so frequently. But if you're waiting to get rid of it, it'll be a couple of weeks, and the vaccine won't be available to you for a couple of weeks anyway. So the answer is treat yourself, get in line, get treated when you can.
if caregiver of someone who is ill, can you still go out to the store, etc., with masks to get groceries or must to-dos until know if you're positive or not?
So this gets into the sort of the general things. If you have someone who's ill, you are more likely to be ill. You may not be symptomatic for 5 or 7 days. So you are a much greater risk for others if you've got a family member who's ill. And consequently, going out shopping, mask or not, is really a bit tricky for the general health. And if you can afford it and have food delivered, that would be better for you. If you can't afford it, then do everything you can. Use a mask and a shield, use gloves, etc.
Okay. Is Lateris protective in any way?
No.
To the point. Home test kits are being developed. Are they reliable?
Not yet, but they will be. We talked about the salivary test. I really think it's coming, but it's not here yet.
A lot of people thanking you for doing this presentation a lot. If you haven't seen them in the box, you're getting a lot of them.
Well, that's nice of everybody. I'm
Yeah.
glad you were able to sit through this. This was a long session.
Yeah, we've actually went a little over time, but I thought it was important to get everybody's questions answered. So any last question before we end the meeting, guys? Okay, I think we're good to go, Dr. Furst. Everybody's just continuing with their thank yous.
All right. Well, thank you all for being so patient. And I hope everyone continues to do reasonably well or even very well. And have a good holiday, everybody.